Actually, our topic would be about gram-negative cocci. And under the gram-negative cocci, so important topics for tonight, for today, would be Neisseria species, because there are several species of Neisseria, and we will also be discussing Moraxella. So let me explain first why did I choose this particular photo as our as for the first slide. So this is an electron micrograph of Neisseria. So they are diplococci, meaning to say they are, pag sinabi natin diplococci, it means that they occur by pair. Um, the difference in with Streptococcus pneumoniae, which is part of my previous lecture, is that this is a gram-negative diplococci. Streptococcus pneumoniae is a gram-positive diplococci. And another thing that you would notice if you're going to draw this one is that this particular diplococci is a coffee bean shape. Okay, so it is a coffee bean shape, and you'll be able to notice the presence of numerous fimbriae. Ano ba yung purpose ng fimbriae? So later on, we will be discussing it. Okay, so and so let's talk about the general characteristics. Okay, so before we talk about the general characteristics, let me explain first to you this photograph. So this photograph is a photograph of the gram stain from the urethral discharge. Sabihin, kinuha yung specimen na to from someone with gonorrhea, or in Tagalog, we call it tulo. So what you'll be able to see, you'll be able to see segmenters in hematology. I think you have already studied that, or the PMNs. And then you'll be able to see them. These are cocci, and this particular cocci is extracellular. And then this is one WBC, and you'll be able to see numerous diplococci inside the cytoplasm. So this is what you call intracellular diplococci. So this particular smear came from the tulo, from the nana of a person with gonorrhea. And this is how it looks like under a microscope. So very interesting. Our lesson for tonight is very interesting because you learn a lot. You learn one of the STIs, or sexually transmitted infection, for tonight. Okay, so let's discuss first the member Neisseriaceae. Neisseriaceae is the family, and we have following members such as Neisseria, Kingella, Aikinella, Simonsiella, and Alaisiella. Para mga pangalan, no? But utang na loob, huwag niyo ipapangalan sa anak ninyo yung Simonsiella, okay, or Alaisiella. Okay, para meron bang ganito rito, Alaisiella. Yeah, okay. And then, Neisseria Kingella. Okay, so most Neisseria. So we will be focusing on Neisseria. And most of them are aerobic, non-motile, non-spore forming, and they are gram-negative diplococci. So they are gram-negative diplococci, and they are oxidase positive, and they are catalase positive. Okay? So, but there are exceptions. Not all of them are actually diplococci. Some of them are rad-shaped. So examples are Neisseria elongata, Neisseria weaver, and Neisseria basiliformis. So this particular Neisseria are gram-negative bacilli. So obviously they are rad-shaped. Okay? Not all of them are catalase positive. So we also have an exemption. So Neisseria elongata, Neisseria nitroreducens, and basiliformis, they are all catalase negative. So that's another exemptions. And then Neisseria weaver is catalase positive. So again, if we're going to check the family Neisseriaceae, this would be their common denominator. So they are plump cocci, coccobacilli, or rods. They are gram-negative and non-motile, and they are aerobic and can grow at 32 to 36 degrees centigrade. So major family would include Neisseria, Kingella, Eikenella, and Simonsiella. So among this family, we will concentrate our discussion for tonight with Neisseria, particularly the human isolates. These two human isolates, Neisseria gonorrhoeae and Neisseria meningitidis. So there are many, as you can see a while ago, there are many species of Neisseria. Okay, okay. So although there are many species of them, resident they can reside in our mucous membrane, but there are only two that are medically important. Only two species of these are encapsulated, and these are gram-negative diplococci, normally pathogenic for humans. So this is your Neisseria gonorrhoeae, common name gonococci, and then Neisseria meningitidis, common name meningococci. Okay, so take note that this is how we spell gonorrhoeae as species. We spell gonorrhoeae like this whenever we are pertaining to the species. But the disease is spelled this way, gonorrhea. But whenever we spell it as scientific name, Neisseria gonorrhoeae. Okay. So again, there are two primary human pathogens. So these are your Neisseria gonorrhoeae and Neisseria meningitidis. So these are human primary pathogens of humans. And then later on, uh, we will also be discussing Moraxella Catarrhalis. Okay, so three important species for today. So Neisseria gonorrhoeae, Neisseria meningitidis, and Moraxella Catarrhalis. So let's talk about the general characteristics of Neisseria. Many of them would require CO2 for growth, carbon dioxide for growth. Hence, they are capnophilic. Okay. So whenever we incubate them, it is best that it will be incubating them in a candle jar. Okay. So we place the petri dishes inside the jar, and then we lit the candle, and then we cover the jar. So once you have covered the jar, the atmosphere inside would be devoid of oxygen. So the fire of the candle will burn out and smoke will come out from the candle. So optimally, the smoke coming out from the candle would be supplying the CO2 needed by Neisseria. However, a more accurate way of using this one is CO2 packet. Okay, so CO2 packet is more accurate way of providing carbon dioxide for organisms. So if alternative electron acceptors are present, such as nitrites, organisms can grow anaerobically, which means if nitrites are present in the in the culture or in the cultural condition or incubation condition, then the organisms can grow anaerobically. So when you say anaerobically, even if you devoid the culture with oxygen, then the organisms can still grow. So the natural habitat of Neisseria species whether Meningitidis or or gonorrhoeae, are the respiratory tract and the urogenital tract. So take note, mucous membranes. Okay, so the mucous membranes of the respiratory tract and the urogenital tract. Okay, so these are the general characteristics of Neisseria. So clinical significance. Okay, so usually some species of Neisseria can actually exist as the flora, usual flora. So when you say usual flora, we are referring to normal microbiota of the upper respiratory and urogenital tract, meaning most isolates are not pathogenic and some are routinely normal flora. In fact, Neisseria meningitidis can be commensals inhabitants in some carriers. So when you say carriers, they carry the bacteria, but they are asymptomatic because they are carrier. However, even if they are carrier, they are potentially infectious. So even if they are carrier, they can be potentially infectious. So let's talk about the primary human pathogens. Okay. So Neisseria gonorrhoeae are always pathogenic whenever it is present. So that's your gonococci. And it is actually one of our STIs, sexually transmitted infection. And then Neisseria meningitidis or the meningococci, as what I've told you, could be a commensal inhabitant of the upper respiratory tract of carriers, and it could become invasive pathogen. So both of them are considered to be as fastidious. Okay, so when they say fastidious, they would require enriched media for optimal recovery. What does it mean? Enriched media means that you have additional nutritive substances that can be added. And usually, this is in the form of blood. But for Neisseria, we usually heat the blood. And whenever we heat the blood, it is no longer blood agar plate because once we heat the blood, it becomes chocolate agar plate because the red color of the blood would turn brown. So it appears this as if you're looking at the chocolate, but there's no chocolate in chocolate agar plate. So again, so I'd like to show you another slide showing the diplococci, the coffee bean shaped diplococci as seen under the electron microscope. So let's talk about the virulence factor for Neisseria gonorrhoeae. Okay, one of them is actually Neisseria, not necessarily gonorrhoeae, but Neisseria, generally speaking, would have receptors for human transferrin. And because of that, Neisseria will compete for iron. So the supply of iron, so Neisseria will be competing with it. Okay, and that's not good because we're supposed to utilize iron. And then, of course, they also have capsule. So this is an electron micrograph view of how the capsule look like when seen under the electron microscope. And again, capsule will prevent phagocytosis. And then since it is a gram-negative bacteria, they have outer membrane. Remember, outer membrane is only seen in gram-negative bacteria. Outer membrane is not seen in gram-positive. So they have outer membrane proteins.
And the outer membrane proteins would contribute for its antigenic variation. And because our immune system is exposed to these particular outer membrane proteins, we will be we will be producing antibodies, but these antibodies are useless. Okay? And it will just bind to the pathogen and will prevent the binding of effective antibodies. So why useless? Because they can't stop the virulence of Neisseria. That's why the author says here it's the antibodies being produced against outer membrane proteins are useless antibodies. So what are these major outer membrane foreign proteins? Okay, so we have the 4A and 4B. Okay, so 4A and 4B. Okay, 4A and 4B would be effective against inflammatory response and complement killing. 4A and 4B is actually short for porine protein A and porine protein B. So they would be responsible for against inflammatory response and complement killing. Complement is our natural defense. The purpose of complement is to lyse bacteria. So it is actually a serum protein. But because of the 4A and 4B, this particular protein, okay, efficacy of complement will be useless. Okay? Protein 2. So this is now your protein 2. Protein 2 is also known as the OPA protein. Okay? So it facilitates adherence to phagocytic and epithelial cells. And then the last one is the protein 3 or the RMP protein. So the other term would be RMP. It blocks host serum bactericidal action of IgG. Meaning to say, because of the protein 3, our IgG would become useless as well. Our antibody would become useless as well. Okay, so this makes Neisseria more virulent, more harmful. Okay, so another pathologic or virulence factor would be the presence of pili. Okay, pili would have several functions. So this is the electron micrograph view of Neisseria. So again, you can actually see here the coffee bean shaped gram-negative diplococci, and you'll be able to see numerous pili. If one pili interact with another pili, one bacterial pili interact with another bacterial pili, we call that as conjugation. And conjugation, this is the function of conjugation. It will aid in exchange of genetic material from cell to cell, or tinatawag natin sex pili. Okay. There are actually 5 colony types of pili. Okay? T1, T2, T3, T4, and T5. T1 and T2 are the virulent type, while T3, T4, and T5 have no pili. Okay? So if you'll be able to see colonies of Neisseria, we should pray that the colonies should not have um, pili. The colonies should belong to T3, T4, and T5. So later on, we will be discussing
how do we distinguish T3, T4, and T5 colonies from T1 and T2? So later on, we will have descriptions for that. So we do not want pili because it will evade our immune system. Iisahan niya yung immune system natin. It will aid in attachment to host tissues. In this particular description, this may pertain to Fimbriae, and it helps prevent phagocytosis. So that's the reason why we do not want pili, and pili will make the bacteria more virulent. It will make the Neisseria more virulent. Okay. Another virulence factor is the presence of LOS, okay, or endotoxin. Okay. Is it different from LPS? Actually, yes. Okay. So the lipid A moiety, so yung lipid A, differentiates it from the LPS. Okay. But anyway, the endotoxin or the LOS also contributes to the virulence. So it is made up of the O antigen, the outer core, the inner core, and the lipid A, which allows it to be differentiated from the LPS. And protease, IgA protease. What is a protease? Okay. Protease is a cleaving enzyme that can cut protein. So that's the definition of the protease. So protease is a cleaving enzyme that can cut protein. And since our antibody, such as the IgA, which is a dimer, is found in the mucous membrane, and Neisseria will infect our mucous membrane. So the Neisseria will literally produce IgA protease, and they will just cut the IgA. So it will just disseminate the infections. And this particular IgA protease can also be found in anal canal. So it is also possible that people who would have unprotected anal sex may also be possible to be infected with Neisseria. So it will just cut our antibodies, so making the antibodies useless. Okay, so that is the IgA protease. Okay, so let's talk about Neisseria gonorrhoeae. Okay, so gonorrhoeae, humans are the only known host. So you will not be able to see, di kayo makakita ng unggoy na may tulo. Okay, only humans. Okay, gonorrhea is actually a Latin word which means flow of seed. Flow of seed. Primarily because when someone is infected with gonorrhea, there is a urethral discharge, which is in the form of pus, or in Tagalog, we call it nana. And that nana was mistaken for semen. Napagkamalang seminal fluid yung nana. So akala ng mga tao before that if you have gonorrhea, seminal fluid will constantly come out from the penis. But it is not a seminal fluid, but it is a pus. But again, the name is, by the way, named after it because urethral discharge was mistaken for semen. Okay, so gonorrhea or the flow of seed. And it is also known as the clap. So clap is the English term for tulo. So in Tagalog, we call it tulo, but in English, it's clap. Clap is a French word for brothel. And during the ancient time, this is where prostitution happens. Brothel. Okay, clapois in French. Okay, so the reportable disease is now known as gonorrhea. Okay, so Neisseria gonorrhoeae is commonly transmitted by sexual contact. Okay, so the primary reservoir are actually asymptomatic carriers. And when we say asymptomatic carriers, majority of those that are asymptomatic carriers are female. Okay, so it is also considered as a national reportable disease. So confirmed cases must be reported to state health laboratories. So this is in cases of USA. And highest rate of infection would be men and women between ages of 20 and 24. But it doesn't mean that if you're not within this age bracket, you will not get infected. For as long as you are engaging in unprotected sexual intercourse, then you are at high risk of getting gonorrhea. Okay. So it has a very short incubation period. So gonorrhea, therefore, a short incubation period of 2 to 7 days, and gonorrhea, therefore, is defined as acute pyogenic infection of the epithelial cells of the urogenital tract, in this case. Okay, as you can see that pus comes out, pharynx, if the person is involved in oral sex, the oral cavity can also be infected, and conjunctiva of the eye. So if infants are infected, so this infant is a neonate, and this particular infant was born from a mother who has Neisseria gonorrhoeae. So this particular condition is called ophthalmia neonatorum. And do you know that ophthalmia neonatorum can actually lead to neonatal blindness? And this can be prevented by dropping 1% silver nitrate during the time that he's born. So this particular 1% silver nitrate is actually known as the Krebs prophylaxis. And Krebs prophylaxis, Krebs prophylaxis is actually Krebs prophylaxis is actually the previous practice, but nowadays you can just add, for example, erythromycin or any antibiotic eye ointment. So eye ointments are now being added to prevent ophthalmia neonatorum. So it can also cause disseminated infections. Let's say, for example, it can cause arthritis. Or if a person was involved in anal sex, unprotected anal sex, the anal canal can also be um, infected. So what will happen actually is like this, no? So for example, this is the urethra. This is the urethra, and you have epithelial cells in the urethra. And if you look at Neisseria gonorrhoeae, we have several fimbriae. You have numerous fimbriae. And then this particular fimbriae will attach to the epithelial cells. So even if you urinate, they cannot easily be detached. So you now have several Neisseria gonorrhoeae at the epithelial cells. And what will happen next is that
WBC, the neutrophils will try to attack them, will try to phagocytize them. So you now have numerous WBC, you now have numerous WBC at the urethra, causing urethral stricture. So if there is a urethral stricture, it will be difficult for us to urinate. So we will have the so-called dysuria, a condition wherein it becomes very difficult for us to urinate. And if there is dysuria, it is as if there's a burning sensation whenever we urinate. Okay, particularly for male. Yeah, no? So pus will always come out. Okay? So let's talk about the clinical infections of Neisseria gonorrhoeae in men. Okay. So um, the incubation period is between 2 to 7 days. Okay? So it is transmitted only by intimate sexual contact. And asymptomatic gonococcal infection is uncommon. So tandaan ninyo, 90% of male would show symptoms of acute infection. So very common yung acute infection. Kasi asymptomatic gonococcal infection is more common in female as compared to male. Okay. So symptoms in male would include dysuria and urethral discharge. So I've already explained to you why there is a urethral discharge, okay, and why there is dysuria. So this would be the normal anatomic structure of the male, okay. So one complication of gonorrhea in male is called epididymitis, okay, and epididymitis is the inflammation of epididymis. So this is your epididymis. Okay? And then there would be urethral stricture. When you say urethral stricture, which I have already explained to you a while ago, we are pertaining to the narrowing of the urethra because of the numerous neutrophils invading the urethra. So this is the urethra is where the urine will come out. So nandito siya somewhere here. Nandito yung urethra. And then there would also be prostatitis. Prostatitis is the inflammation of this one, the prostate gland. So these are the complications of gonorrhea in men. Okay. How about in women? Okay. Almost 50% of women, whenever being infected with gonorrhea, they appear to be asymptomatic, meaning to say, they will not show any signs and symptoms. And the endocervix is the most common site of infection. So this is an example of endocervix that has gonorrhea. So you can see pus here. Okay, if ever they are symptomatic, um, they would also experience dysuria. So dysuria is the difficulty in urination. There would also be cervical discharge and lower abdominal pain. So this is for women. Okay, so whenever women are infected with gonorrhea. Okay, however, the complications in women would actually be more severe than men because once women are infected with gonorrhea, so they can actually get PID, pelvic inflammatory disease, which could lead to sterility and ectopic pregnancy, wherein pregnancy would occur out of the fallopian tubes. And of course, another complication would be
the presence of perihepatitis, also known as the Fitzhugh-Curtis syndrome. So what is perihepatitis or Fitzhugh-Curtis syndrome? Okay. Fitzhugh-Curtis syndrome is the complication of a pelvic inflammatory disease. Okay? So it is the inflammation of the hepatic capsule and the diaphragm because of, because of the proximity of diaphragm and and hepatic capsule. There would be like uh formation of the Virulence string sign. It is actually the adhesion between liver and abdominal wall. So this is now what you call the perihepatitis. So para siyang Virulence string. So yung liver, nagkaroon ngayon ng string because of the pelvic inflammatory disease. Okay, so liver, this is the abdominal wall and then this is the liver. So parang nagkaroon ng string. Okay, so this is what you call perihepatitis, one of the severe complications of pelvic inflammatory disease in women. Okay, so there are also other sites of clinical infections for Neisseria gonorrhoeae. So one of them could be, it is a blood-borne dissemination. So meaning to say, um, gonorrhea becomes disseminated in our circulatory system. So it is characterized by the presence of fever, intermittent bacteremia, and even rashes on the extremities. And women, okay, strains that mostly affects women are the AHU strain. So this refers to arginine, hypoxanthine, and uracil strain. So the AHU strains are the strains that mostly affecting women. So in order for us to determine if bacteremia has already occurred, then we have to collect blood from the patient and culture it, okay, in blood culture medium, and the anticoagulant of choice is known as um, usually when ito pala, I'm sorry. Whenever we want to do blood culture, we usually collect blood using SPS as anticoagulant. So SPS is known as the sodium polyanethol sulfonate. However, in cases of suspicion of gonorrhea, we should not use SPS because SPS will inhibit Neisseria gonorrhoeae. So instead, we have to use gelatin to neutralize the effect of SPS. So we use blood culture with SPS plus gelatin so that SPS will no longer inhibit the growth of Neisseria gonorrhoeae. I hope that's clear. Okay, so here's another example. Here's another example of the result of blood-borne dissemination. So if there's already a septicemia or bacteremia, so there's also a chance that some of the organisms will go to our joints, causing us to have gonococcal arthritis. So it is a purulent arthritis as a result of disseminated gonococcal bacteremia. And then there are also what you call extragenital infections. So again, when we say extragenital infections, it is the these are the infections outside the urogenital tract, such as, for example, it's also a possibility for us to get oropharyngeal infections or pharyngitis. It's also common for people with gonorrhea to have um, anorectal infections, meaning to say the anal canal is affected if a person is involved with MSM. So men having sex with men, particularly if the intercourse was actually unprotected, meaning to say without any condom at all. Now, women can also get anorectal infection because of the proximity of the anus from the vaginal opening. So 30 to 60% of women with genital infection can also get anorectal infection, but it doesn't necessarily mean that that particular woman was involved in anal sex. Okay? So, as a result of anorectal infections, there would be rectal pain, and bloody stool samples. So, most infections are asymptomatic or have non-specific symptoms. Okay, so in cases of suspicion of anorectal infection, so um, anal swab can be used to collect samples. This one I have already explained to you a while ago. Ophthalmia neonatorum. So, gonococcal eye infection that occurs during vaginal delivery through infected birth canal. So, if not treated with CREDS prophylaxis, but nowadays we are now using erythromycin eye drop, newborn blindness can occur. So, every infant at birth by law must be treated. So, whether the mother has gonorrhea or not. So as a form of prophylaxis, then we should treat the eye of every infant. And it is already a law. Okay, so let's talk about specimen collection. So look at this, guys. It's really painful to have gonorrhea and more painful to have the specimen collected. Imagine this. Okay, genital site is the site. So you collect the specimen. Says here, if there is a purulent discharge, then you collect the purulent discharge, and that's the end of the story. This is where the pain happens. If there's no discharge, you insert the swab, and just imagine, and slowly rotate it. Okay? There's no swab. So the swab will be inserted at the meatus of the penis, and then we rotate it. For women, so there is also an endocervix swab, and it's also equally painful because speculum will be used to to swab, okay, to swab. So specimen collection would rather be very invasive, not really invasive, but it could be painful for patients. So that's the reason why if you are tasked to collect the specimen, usually medtechs are not collecting it, but sometimes we are, especially if if the patient is due for gram staining or for culture. Okay, so sometimes we are the ones who are collecting it. Okay, so aside from that, rectal culture, you insert swab 4 to 5 centimeter into the anal canal. So that's very deep, 4 to 5 centimeter. And then oropharyngeal, the eye, blood or joint fluids. Blood can be um, submitted for suspicion of septicemia. Joint fluids for gonococcal arthritis. And when we say eye, we do not send the entire eye, but maybe this particular slide pertains to the swab. If there's a purulent discharge coming out from the eyes. Okay, when possible, notification of pending Neisseria sample should be made to the laboratory. Okay, so the preferred swab for specimen collection would be either dacron or rayon. So actually, dacron or rayon is actually much thinner, fortunately, as compared to the cotton swab. We do not want cotton swab because cotton contains calcium alginate. Okay? Calcium alginate, the cotton swabs are inhibitory to the growth of Neisseria gonorrhoeae. And then we plate the sample directly to selective medium, gonorrhea selective medium. So later on, uh, we will be we will be discussing what are the selective medium that we can use for culturing Neisseria gonorrhoeae. So if the specimen is to be sent out to the laboratory, we should use a transport medium. Okay, so transport systems are available that contains selective media and CO2 at the same time. So one of them is the Gembec, Gonoblock, or Transgrow The specimen is rolled in a Z pattern on the media. So later I'll show you the picture. So if you cannot plate it and it has to be sent into a remote laboratory, so Amy's medium can be utilized. So this is the swab. And then after you have collected the specimen, you place the swab here in Amy's transport medium. So this is an example of the Gembeck plate. So Gembeck stands for Jonathan E. Martin. So that's the name of scientist who discovered it. Jonathan E. Martin Biological Environmental Chamber. So that's why it's called Gembeck. So Z-shape. Hindi dahil kay Zorro. Okay? Z-shape. And then we place it here. And then we send it to the laboratory. So we do direct microscopic examination. So for urogenital specimen, we can do the direct gram stain. But for pharyngeal specimen, it is not recommended because we have a normal flora of Neisseria in our pharynx. So that's not being recommended. For urethral discharge of symptomatic nail, what are we expected to see? We can actually see a kidney bean-shaped gram-negative intracellular diplococci. So again, when you say intracellular, it is found inside the WBC, and the kidney bean shape, 89% would most likely be gonococcal infection. For a virulent forms, meaning to say, no pili. Again, T3 and T5 are a virulent. So they would have the extra cellular gram-negative diplococci because they are a virulent. But if it's virulent, most likely you would see them intracellularly. Again, so when you say intracellularly, it means that they are found inside the WBC. Okay. In women, 50 to 70% correlation of direct gram stain with culture. So we do not usually advocate performing gram stain in women because it is less diagnostic, because women would also have vaginal flora of similar morphology. So for women, having a gram-negative diplococci is not diagnostic, but for male, it is actually diagnostic. Okay. However, if women would have discharge, gram stain may be helpful. But still, we need culture. Still need culture to confirm it. For male, kapag meron nang nakita na urogenital specimen na ganito, hindi na pinapakulture yan. Bibigyan agad ng antibiotics. But for women, okay, culture is necessary for confirmation. So gram stain with more than 5 ppm neutrophil per field with no bacteria suggests non-gonococcal urethritis or NGUs. What is NGUs? When you say non-gonococcal urethritis, these are other bacteria that can cause sexually transmitted infection, such as urea plasma is a non-gonococcal urethritis, or even Haemophilus ducreyi. So can cause non-gonococcal, Haemophilus ducreyi is not. Urea plasma na lang. Urea plasma, urea liticum. So it's the most common example of non-gonococcal urethritis. Okay, so direct gram stain. So letter A, this is the picture of letter A. Here is the urethral discharge showing intracellular and extracellular gram-negative diplococci diagnostic for Neisseria gonorrhoeae, because here the patient is male. Okay. Here you see a lot of neutrophils. There are many neutrophils, but there's no bacteria. This is the bacteria.
bacteria, bacteria, bacteria. But here, many WBC, but no bacteria. So it is suggestive of NGU. So again, an example of NGU is ureaplasma, urealyticum. So we will actually talk about it more of it during the finals. And this is an example of a modified chocolate agar. Okay, so chocolate agar supplemented with inhibitors. Okay, so inhibitors are antibiotics that will prevent the growth of gram-positive, gram-negative, and yeast. Okay, so it prevents the overgrowth of normal flora so that only Neisseria gonorrhoeae will occur in this modified chocolate agar. So it is inoculated culture media must be incubated at 35 degrees centigrade with 3 to 5% CO2. So CO2 incubator um, will generate pouch or candle extinction jar. So either use CO2 packet or candle jar. So these are this table is very important. Okay, so I want you to study this table. This table will tell us what are the different culture media that we can use for the culture of both Neisseria gonorrhoeae and Neisseria meningitidis. So, for example, Thayer Martin medium contains vancomycin, which prevents gram-positive organism, colistin, which prevents the growth of gram-negative organism, and nystatin, which prevent the growth of yeast. And then the modified Thayer Martin medium has trimethoprim added on it to prevent swarming of proteus. And then Martin Lewis medium would have also the same vancomycin and colistin, but instead of nystatin, it has anisomycin, okay, which of course prevent the growth of the yeast. The New York City medium would also have vancomycin, colistin, but instead of nystatin or anisomycin, it has amphotericin B. It's actually more expensive and prevent the growth of the yeast. And then the GC-LEC medium contains vancomycin and lincomycin. Now you have two antibiotics for gram-positive bacteria in GC-LEC medium. Colistin, which prevents the growth of gram-negative, amphotericin B, which prevents the growth of yeast, and trimethoprim, which prevent the swarming of proteus. Okay, so I want you to study the different culture media that we can utilize for the isolation of Neisseria. So again, as what I've told you, there are actually three distinct colonies. Okay, so anyway, this is an example of a modified Thayer Martin medium. So you would expect the colonies to be small, gray to tan, translucent, and raised. And gray and tan, translucent, and raised. Okay, but again, we have five types of colonies: T1, T2, T3, T4, and T5. So T1 and T2 are expected to be small rays and appear to be bright whenever they are being reflected in light. T3 and T5 are large and flat colonies. Okay, very important. Why? Because T1 and T2 contains virulent villi. And T3 up to T5, they are considered to be as a virulent. T1 and T2 are virulent. So this could be T5, that's big, but the smaller colonies could be T1 or T2. Okay, so let's talk about the microscopic morphology. Okay, so it says here, gram stain must be performed on suspected isolate to verify the presence of gram-negative diplococci. So here, very obvious that we are looking here at gram-negative diplococci. Some gram-negative bacilli or rods may occur even if you are using the gonococcal selective medium.
because of the possibility of Kingella here. Kingella can be present. So, and Acinetobacter as well. So, to differentiate from gram-negative diplococci, strict organism to a plate with a 10-unit penicillin disc, and after incubation period, okay, look for the presence of the zone of inhibition and examine the morphology, such as this one. Okay, so if there's a zone of inhibition, then most likely it is Neisseria. Okay, and then when you look at the morphology, if we're looking at gram-negative diplococci, then it is Neisseria. So this could be Kingella and this could be Acinetobacter. Okay, so that we can differentiate Neisseria from other bacteria. But this one is very important, the 10-unit penicillin disc. Another test for Neisseria gonorrhoeae is called the oxidase test. Okay. So we can actually do oxidase test either on the cool or in the filter paper, or we can also do it in the culture media itself. So if we're using oxidase test, so all we have to do is to get, if this is the filter paper, we place the colonies here, and then we add oxidase reagent. So there are two possible types of oxidase reagent. So it could either be 1% dimethyl paraphenyl 1% dimethyl paraphenylene diamine dihydrochloride, and the other one is the tetramethyl paraphenylene diamine dihydrochloride. Break it down. Okay, so these are the two active components of the oxidase reagent. So we add the reagent on top of the filter paper, and then we get colonies from the plate and rub it in the filter paper using sterile no nichrome loop or applicator stick. So within 10 seconds, if it's a purple, it's positive. But if it remains yellow or brown, so that is a negative for oxidase test. So usually, Neisseria is positive for oxidase test. We can also do oxidase test by adding directly the reagent in the plate. Okay, so add reagent in the plate. If the colony turns deep purple to black, then the test is positive. Okay, so commercially oxidase strips may also be available, but if there's no change in color, then that's negative. So what's the principle of the oxidase test? The reagent renders tested colonies as non-viable, so subculturing suspected colonies may be required. So kapag nilagyan mo ng oxidase reagent, mamamatay na yung bacteria. So kailangan before mo siya lagyan ng oxidase reagent, ma-subculture mo muna siya so that you should still have the live specimen. Okay, so again, oxidase test can either be performed in the disc or in the colony itself. So, however, there is also a definitive identification of Neisseria. So other oxidase positive gram-negative diplococci can grow also on selective medium. So hindi lahat ng positive sa oxidase ay Neisseria gonorrhoeae. That's what it means. Because there are also other Neisseria that could also be positive with oxidase test, such as Neisseria cinerea, Neisseria meningitidis, and even Moraxella Catarrhalis. So further tests are needed. Okay, so what are these further tests? Okay, so again, a very important table. So the conventional type is using the CTA agar. The CTA agar. CTA is cysteine 50-case agar. And the purpose of CTA is for carbohydrates fermentation. But there are other more rapid tests, such as the chromogenic coagglutination, modified conventional chromogenic enzyme. So these are actually more expensive, but more specific, and confirms, and it can actually confirm the presence of Neisseria gonorrhoeae. Okay,
So these tests are called cultural tests or the culture-based test. What does it mean? Bakit siya tinawag na culture-based test? Because the first requirement is you should grow suspected colonies first in the culture. So kailangan mo siyang, you need to grow first the colonies in the culture. So that's why it's called culture-based test. And then we also have nucleic acid amplification test. So this one is a molecular method. So PCR can also be used for identification of Neisseria gonorrhoeae. And there are different manufacturers that can actually use PCR for the identification of Neisseria gonorrhoeae. So let's talk about the conventional method or the cheaper method for identifying Neisseria gonorrhoeae. So the traditional method is known as the CTA, the cysteine trypticase agar, and it contains a single carbohydrate. So we can actually test for four sugars: glucose, maltose, lactose, and sucrose. So the principle of this one is that we use phenol red. And what's the purpose of phenol red? Phenol red is pH indicator. Okay, so your phenol red is, is the pH indicator. So this is a carbohydrate fermentation test. So this is a carbohydrate fermentation test. So take note that whenever fermentation takes place, it will turn the medium acidic. If no fermentation has taken place, the medium remains alkaline. So if the medium becomes acidic, phenol red would be yellow. If the medium becomes alkaline, phenol red would be pink or red. So a positive result, therefore, in carbohydrate fermentation test is yellow. And Neisseria gonorrhoeae is only positive for glucose. Okay? But for Neisseria meningitidis, it is positive for both glucose and maltose. So take note, this is the principle of the carbohydrate fermentation test. So Neisseria gonorrhoeae is positive and it's yellow. And Neisseria meningitidis is positive for both glucose and maltose. And there's also a rapid test, which wouldn't require you to get a tube, and it would be much easier. So there's, for example, Hardy Diagnostic have the CarboFirm Neisseria test. So it's much easier. So 2 to 4 hours from pure culture, but the problem is that sometimes there's a weak acid production from glucose for some strains of Neisseria gonorrhoeae, which can result to a false negative result. So misidentification of Neisseria fabula as Neisseria meningitidis is also a possibility because there are some also sucrose negative strains of Neisseria subflava. Okay, Neisseria cinerea will also give a positive glucose reaction. So again, carbohydrate utilization test is not really that accurate, and you should always correlate, or doctors should always correlate the result of the laboratory with that of the clinical signs coming from the patients and history as well. And then there's also what you call the chromogenic substrates. Uh, these are the chromogenic substrates, the gonocheck and the Bacticard Neisseria. So it detects enzyme that hydrolyze colorless substrates, produce color end products. So again, the problem noted here would be misidentification of non-pathogenic species, and to address the problem, we should only test isolates coming from the selective media. And then the multi-test method is actually a conventional chromogenic enzyme methods that combines both the enzyme substrate with other biochemical tests. Okay, so as you can see, there are several tests available for the diagnosis of Neisseria gonorrhoeae. And it is also very important for us to differentiate Neisseria from Moraxella and Kingella. So we will be discussing Moraxella in detail later on. But just so to give you ideas, these are important characteristics for Moraxella. So Moraxella can reduce nitrate, nitrogen dioxide, and tributylene hydrolysis. Okay, so that's one feature that is kind of unique for Moraxella. Okay, and of course, immunologic assays would also be possible. And one of that would be the coagglutination assay. So when you say coagglutination assay, um, we actually use reagent, okay, attached to killed S or U. So we use monoclonal antibodies. So if this is S or U's, we have monoclonal antibodies. And this particular antibodies is against Neisseria gonorrhoeae. So if a person is positive with gonococci, so that person would have co-agglutination of S or U's, as you can see here. It is sensitive, but false positive may occur due to cross-reaction with other species of Neisseria. So that is co-agglutination. So again, in this structure, this is S or U's, dead S or U's. This would be the monoclonal antibodies, and then this would be the gonococci. And this is how a positive reaction looks like. And immunologic assay would also be available as well. So aside from the coagglutination, we also have the fluorescent antibody testing. We are also using monoclonal antibodies against a specific protein, which we have discussed a while ago, the core protein. And then we add fluorescent tags. So usually these fluorescent tags is in the form of fluorescein isothiocyanate. Fluorescent isothiocyanate will allow gonorrhea to glow in the dark when you use a fluorescent microscope. So it's much easier for us to look for Neisseria gonorrhoeae, and also it is actually more sensitive than using a gram stain. And MALDI-TOF, this one is one of the best method. MALDI-TOF stands for Matrix Assisted Laser Desorption Ionization Time of Light Mass Spectrophotometry. So it identifies unique protein signatures of Neisseria gonorrhoeae. So again, not all laboratory can actually afford to have a MALDI-TOF system. And a more, of course, expensive way of diagnosing Neisseria gonorrhoeae would be by means of nucleic acid assay. So we are now in molecular technique. So advantage, it is rapid, is increase in sensitivity, specificity, and ability to test with non-invasive, because you can just use first morning urine specimen, not even the swab. Diba? That's nice. However, it is not approved yet as a test of cure, not approved for pharyngeal or rectal specimen, and do not allow for recovery of an organism to be used for susceptibility testing. Unlike when you culture it, we can also perform susceptibility testing, meaning to say, we can check which antibiotics would be effective for the isolated colonies. So that's a disadvantage of nucleic acid assays. Because we want to know if the drugs that we are drinking would still be effective, because nowadays Neisseria gonorrhoeae has become a super bug, meaning to say Neisseria gonorrhoeae
has become resistant to many antibiotics. So we have what you call a plasmid-mediated penicillinase-producing Neisseria gonorrhoeae, or the PPNG, because of its beta-lactamase production. We also have the chromosome-mediated penicillin resistance, the PENR. It is a beta-lactamase negative, but it can alter the PBP, or the penicillin binding proteins. And we also do have the plasmid-mediated tetracycline resistance, the PRNG. So there are now many um, resistant forms of Neisseria gonorrhoeae. And aside from that, we also have the chromosomal mediated resistance, which is resistant to both penicillin and tetracycline. We also have the chromosomal mediated spectinomycin resistance. And we also have the chromosomal mediated fluoroquinolones resistance, FluorNG. So as you can see, no, Neisseria gonorrhoeae nowadays have become a superbug and resistant to many antibiotics. So, do you still have treatment? Well, according to CDC, back in 2007, they are uh, recommended use of fluoroquinolones. But because of the resistance, yung QRNG, hindi na ginagamit yung fluoroquinolone. So the treatment nowadays would be cephalosporin, the third gen. And one of them is ceftriaxone. And ini-inject siya. So if you have gonorrhea in let's say for example, it in the penis, in the urogenital tract, it will be injected, okay, near that area. So most probably sa buttocks. And it's so painful. Like, okay? Or sometimes it can also be given intramuscularly, but most of the time it is being injected the area near the site of infection. And it is also prescribed if a person has co-infection with chlamydia trachomatis. So aside from ceftriaxone is a person is also being given azithromycin. Just so to be sure, especially if okay, that person has co-infection with chlamydia trachomatis. Okay, so that's the end of Neisseria gonorrhoeae. So let's now proceed to another organism. So this time, let's talk about Neisseria meningitidis. So let me just explain to you this picture. It says here, Neisseria gonorrhoeae versus Neisseria meningitidis. How many times do I have to talk? Okay, so this is from the urethral discharge. And this probably could come from CSF. So as you can see, so urethral discharge would have more neutrophils as compared to the one found or isolated from the CSF. So Neisseria meningitidis is found only in humans. So take note that Neisseria meningitidis could either be commensals or invasive. And it is an important etiologic agent of epidemic meningitis and meningococcemia. Let me clarify the term. Epidemic meningitis. Why do we call it epidemic meningitis? Because it can easily be transmitted. It could be transmitted by means of respiratory droplets, the same way how COVID-19 is transmitted. And what's the difference between epidemic meningitis and meningococcemia? Well, when you say meningococcemia, it means that the bacteria are found in the blood. But when you say epidemic meningitis, the bacteria have already invaded the central nervous system. So that's the difference. Okay. So it will usually start first as meningococcemia before it can actually infect your CNS. It is rarely associated with pneumonia, purulent arthritis, and endophthalmitis, and has also been recovered from urogenital and rectal sites as well. So, Neisseria meningitidis is found on the mucosal surfaces, particularly at the nasopharynx and oropharynx in approximately 30% of the population. And it is transmitted by close contact with respiratory droplet secretion from a carrier to a new host. So that's the reason why it is called epidemic meningitis. Only a few colonies or colonized hosts would develop the meningococcal states. So it has the highest incidence in infants and adolescents. So fortunately, we now have vaccines against Neisseria meningitidis. So who are at-risk populations? As clinic patients, meaning to say, these patients has undergone splenectomy already, so their spleen is removed, so they are actually more immunocompromised. And individuals with complement deficiencies. Again, remember, complement is a serum protein and it is a natural defense of our body. If you're deficient with that, you are at risk of getting Neisseria meningitidis infection. Okay, population at risk of serious disease would also include smokers or people who are exposed to smoke and individuals with concurrent upper respiratory tract viral infection. Okay, so who, why do we call it epidemic meningitis? Because it can easily be spread, particularly if you are living in a crowded conditions, such as in military camps or in the dormitory of college students. So meningococcus disease is uncommon in developed nations, and unfortunately, Philippines is not yet, I'm not saying never, Philippines is not yet a developed nations. Kaya sa susunod na halalan, kay lugaw tayo. Joke lang. Okay. Anyway, Neisseria meningitidis, the incubation period is between 1 to 10 days by colonizing the mucosa. So, sabi ko nga sa inyo, it will first start sa respiratory droplet. So, mapupunta siya ngayon sa mucosa. So, small number of bacteria have entered the bloodstream. So, kapag nasa bloodstream, we call it meningococcemia. And then it will now go to CNS. Pag nasa CNS, we now call it meningitis. It will lead to septicemia or meningitis. Okay? So, what would be the signs na meron ng meningitis yung isang patient? So, frontal headache and stiff neck, confusion, photophobia, nausea and vomiting, sometimes fever, and purulent meningitis. Okay? So, unlike meningococcemia, it's totally different disease. Okay? So, magkakaroon ng petechiae. And the reason for the presence of the petechiae is this one, DIC. DIC stands for disseminated intravascular coagulopathy. And this is the reason why bakit merong petechiae yung mga tao na merong meningitis or meningococcemia. Purpura, tachycardia, and hypotension. Okay? Fulminant disease. Okay? So, it's also possible that the adrenal glands, which is a gland found on top of the kidneys, would rupture. So, and causing its hemorrhage. We call it the Waterhouse Friderichsen syndrome. And other complications would include arthritis, pericarditis, pneumonia, conjunctivitis, and urethritis. So again, ito yung petechiae. Kita ninyo? Usually, nagkakaroon tayo ng petechiae kapag mababa yung platelets natin. And then, it will lead to DIC. And DIC could be fatal. Kasi nag-clog yung blood vessel natin. And this is the adrenal gland. So whenever it ruptures, the condition is known as the Waterhouse Friderichsen syndrome. So how do we diagnose Neisseria meningitidis? So the primary specimen of choice is TSF, which is collected by means of lumbar tap. Okay? Painful. May anesthesia pala. So, a needle is inserted between two vertebrae, between third and fourth vertebrae. Okay, and blood for meningococcemia is also possible. So we have to use a non-SPS containing blood collection system, nasopharyngeal swabs or aspirates, joint fluids, and less commonly would be the sputum and the urogenital sites. But pinaka-common tong first three: cerebrospinal fluid, blood, and nasopharyngeal swabs or aspirates. So this is how the gram stain look like. So of Neisseria meningitidis, take note ha, halos pareho din siya ng Neisseria Gonorrhoeae. So meningococci appear as intracellular. Ito yung intracellular, nasa loob. Or even extracellular, nasa labas, extracellular. Okay? So CSF specimen. Okay? In order for us to improve our isolation rate, especially during direct examination, so at least 1 ml should be centrifuged so that we examine the sediment. And the sediment is the one that we will be using for gram staining. So a more ideal type of centrifuge is the cytocentrifuge. So it is recommended for best results. Okay, so notice again the presence of intracellular and extracellular gram-negative diplococci. So culture, we can actually use sheep's blood agar and chocolate agar. So for specimen with normal flora, we use the selected medium. So just like your Neisseria Gonorrhoeae, we can incubate it at 35 degrees with 3 to 5% CO2. And we have to examine the plate daily for the next 3 days. So if you are suspecting the colonies with Neisseria meningitidis, you have to use at least biosafety level 2 cabinet. Okay? So, ayan. So, this is how we usually isolate Neisseria gonorrhoeae. So, as you can see, this is the blood culture sample. So, dito natin ilalagay yung blood. So, non-SPS. SPS is inhibitory. So, we have to subculture it into the, so usually, we are using the Bactec medium, Bactec by Beckton Dickinson. Then, we subculture it into chocolate agar or blood agar. Yung blood agar ito, blood agar. And McConkey agar. Okay. So, we gram stain blood agar. So, makita kayo ng gram-negative cocci. And then, we can also do the oxidase test. Kita ninyo na pag nag-perform kayo ng oxidase test, positive. Kasi merong blackening or purple. And pag antimicrobial susceptibility testing yung pinaka-last step. So that we'll be able to know which antibiotic would be best for Neisseria gonorrhoeae. So identification is based on the colony. So we have the colony morphology, microscopic morphology, and the oxidase test. So colonies would usually grow between 18 to 24 hours, and mapapansin niyo that the colonies are medium-sized, gray, convex, tapos medyo mucoid, strains, and blood underneath colonies tend to have green tinge. Hindi natin masyado kita kasi top view ito. Okay, after 48 hours, yung nasa left side ay ito yung chocolate agar plate. Ito naman yung blood agar plate, both of which can be used for Neisseria meningitidis. So, again, for Neisseria meningitidis, would expect oxidase test to be positive, and definitive test can be made via the carbohydrates utilization test. Katulad ng in-explain ko kanina, ang Neisseria meningitidis is positive for both glucose and maltose. Hindi katulad ng Neisseria gonorrhoeae, it is only positive for glucose. Chromogenic enzyme test and multi-test assay. If testing identifies and isolates as Neisseria meningitidis, we should do the serotyping. And of course, a more expensive technique would be molecular technique and the Malditos. Yan. So, ito yung example ng BSL 2, Biosafety Level 2 Cabinet. So, if you You cannot just open Petri dishes with Neisseria meningitidis without using the BSL kasi you might possibly inhale the colonies and that is enough for you to get infected. Kulang pa nga ito eh. Hindi siya nag-face shield. At this point, dito dapat ginagamit yung face shield. So, in 2000, 2 cases of laboratory-acquired meningococcal diseases were reported to CDC. And take note ha, both were clinical microbiologists who examined plates, performed gram stain, subculture, and performed slide agglutination on patients isolated on open bench. Ibig sabihin, hindi sila gumamit ng BSL-2. So, CDC recommendations to prevent future such disease, everyone, including medical technologies, should work under BSL-2 cabinet. Okay? So, para hindi tayo mahawa habang nagte-test tayo for Neisseria meningitidis. Is there a treatment? Fortunately, there is. Again, penicillin for confirmed meningitis. But then again, baka may mga resistant na to penicillin. So, third generation cephalosporins for meningococcemia. So, again, magkaiba si meningitis sa meningococcemia. For close contact of patients, so pwede palang mag-prophylaxis. Like for example, yung isang hospital merong outbreak ng Neisseria, pwede silang magkaroon ng prophylaxis such as rifampicin, ciprofloxacin, azithromycin if ciprofloxacin is resistant. Okay? So routine susceptibility testing is not recommended. And chemoprophylaxis is also not recommended for asymptomatic carriers. Okay? So that is for Neisseria meningitidis treatment. So pwede pala, no, yung mga bantay ng patient, yung mga nurses or attending physicians who are in direct close contact with patients can take chemoprophylaxis. As what I told you a while ago, there is already a vaccine for Neisseria meningitidis. So we call it the 2 quadrivalent polysaccharide protein conjugate vaccines for some subtypes, particularly for types A, C, Y, and W135. So, who should be receiving the vaccines? Military recruits, mga sundalo, or clinic patients older than 2 years of age, lab scientists who are working with Neisseria meningitidis, and other high-risk groups. Yan. And in 2014 and 2015, 2 vaccines were already approved for serogroup B. Ito naman, ang vaccine na to is a conjugated vaccine from other bacteria bound to meningitis group B outer membrane proteins. Ito yung mga conjugated proteins. Okay? So recommended for young adults aged between 16 to 23 years. So it provides short-term protections against 91% of US meningococcal B strains, and it is being administered as 2 or 3 dose series. But sa atin, meron na din kasi yung baby ko it is also part of his routine immunization. Okay, so that ends Neisseria meningitidis. And for now, malapit na tayo matapos. So kapit lang kayo dyan, guys. We will now be discussing Moraxella Catarrhalis from family Moraxellaceae. So do you know that Moraxella Catarrhalis is a normal commensal of the respiratory tract? So we usually have Moraxella Catarrhalis. It is an important opportunistic pathogen isolated only from humans. Okay, so it is considered as the upper respiratory tract infection in otherwise healthy children and older adults. And so also, aside from upper respiratory tract, lower respiratory tract infections are also seen, especially in patients with COPD, or yung tinatawag natin chronic obstructive pulmonary disease. And the predisposing factors for Moraxella Catarrhalis include being of advanced age, immunodeficiency, neutropenia, and chronic debilitating diseases. So these are the predisposing factors. So clinical infections, it is considered as the most common cause of otitis media. Ito yun, no? Infection of the middle ear o yung luga.
sinusitis, rare life-threatening systemic diseases such as endocarditis, meningitis, and bacterial tracheitis. Yung sa trachea naman, yung affected. Severe infections may also occur in immunocompromised hosts and hospital outbreaks. So these are life-threatening. Huh? Okay. And for the specimen collection and culture morphology, so we usually use middle ear effusion. So lalagyan ng fluid yung middle ear so that it would be easy for us to collect the specimen. We also collecting it from the nasopharynx, so swab natin, or sinus aspirate sputum or bronchial aspirate. So we can actually collect specimen from from sheep's blood agar and chocolate agar, smooth, opaque, grayish to white colonies. So this is the description. The colony appears like a hockey puck, parang hockey puck, or pag minsan wagon wheel. Wagon wheel. Ayan, ito yung hockey puck or wagon wheel. And this is how they look like under the microscope. And one of the tests for Moraxella Catarrhalis would be the butyrate esterase reactions. Ito yun. Where in purple color is a positive reaction. So, can grow between 35 to 37 degrees and inhibited on gonococcal selective medium with colistin. Pero kapag resistant yung Moraxella sa Catarrhalis sa colistin, pwede pa rin sila mag-grow. Kaya nga, hindi natin pwedeng gamitin yung culture media for Neisseria for the cultivation of Moraxella Catarrhalis. So treatment, so most isolates produce beta-lactamase. So unfortunately, it is resistant to ampicillin and amoxicillin. Kaya we have to use amoxicillin clavulanic acid. Ito yung co-amoxiclav or yung augmentin, or extended spectrum cephalosporins, azithromycin, skinolones, and the combination of trimethoprim sulfamethoxazole complex. So itong drugs na to are ideal drugs for Moraxella Catarrhalis. And ito na talaga yung pinaka-last topic. We will now be enumerating what are the other commensal Neisseria species. So to start with, when we say commensal Neisseria species, these commensal organisms are found in respiratory specimen, usually identified by Gram-Stain and gross colony morphology. We consider them as the usual oral biota. So further testing is not done. So if isolated from sterile site, we have to differentiate it from Neisseria, from pathogenic Neisseria, such as Neisseria Meningitidis or Neisseria Gonorrhoeae. So ito nga. So infections reported to be caused by Neisseria species other than Neisseria Gonorrhoeae and Meningitis. Pwede rin pala sila mag-cause ng meningitis, endocarditis, prosthetic valve infection, bacteremia, pneumonia, empyema, bacteriuria, stomatitis, ocular infection, and even dog bite. Can you imagine that, no? So, this particular supposed to be non-pathogenic can be pathogenic, particularly if you become immunocompromised. Okay, so we will be discussing them one by one. And commensal Neisseria group are actually divided into 3 groups, no? So the group 1 are the traditional pathogens. So pag sinabi natin traditional pathogens, ito yung mga Neisseria Gonorrhoeae and Neisseria Meningitidis. And then group 2, commensals that grow on selective media. And then group 3, commensals that do not grow on selective media. So group 2 and 3, okay, are further divided into the basis of their carbohydrates fermentation test. So these are the list of non-pathogenic species, but we will just be discussing some of them. So let's start with Neisseria cinerea pala. So it has been known to be misidentified with Neisseria gonorrhoeae kasi nga naman halos pareho sila ng itsura. Neisseria gonorrhoeae is also, cinerea is glucose negative. Yun yung difference. This is glucose negative, pero yung Neisseria gonorrhoeae is glucose positive.
Pero sa itsura, sa gram stain, so hard to differentiate them. So the problem is that glucose was being interpreted as positive when testing with some commercial kits. Kaya nga, as much as possible, mas maganda pa rin gamitin yung cysteine, yung CTA medium. Okay? Additional tests can be done to suspiciate suspicious colonies. Okay, so this is how the appearance, this is how Neisseria cinerea appears 48 hours on sheep's blood agar, though they are almost similar with that of Neisseria gonorrhoeae. Okay, another one is Neisseria lactamica, commonly found in nasopharynx of infants and children. So carriage rates peaks in children at about 2 years old, steadily decline, but it is rarely isolated in adults. So only Neisseria species that use lactose. Okay, so siya lang yung positive sa lactose fermentation. So ang problem is that it has a similar colonies with Neisseria Meningitidis. So additional testing is required to speciate. So ito nga, Neisseria, this is how Neisseria lactamica appear 48 hours on sheep's blood agar and chocolate blood agar. And then another one is Neisseria mucosa. Ito naman is consisting of large, most of the time adherent to the agar and very mucoid colonies. So malalaking colonies very adherent to the agar and usually isolated as a non-pathogen from the nasopharynx of children or young adults. But it is also documented to cause pneumonia in children. And it is associated with bacteremia and endocarditis in patients with neutropenia. Then another one is Neisseriaceae. So it is dry, wrinkled, and appears like breadcrumb. And along with subflaba, Biobarperflaba, are usually the two most common species found in respiratory tract of adults and has been reported to cause endocarditis. So after 48 hours, makapansin niyo yung Neisseriaceae is somewhat wrinkled, yung colonies ng Neisseriaceae. And then Neisseria subflaba. So the term subflaba means less yellow, and it is part of the upper respiratory microbiota, consisting of 3 biobars that differentiated from one another by their pattern of carbohydrate utilization. So it can cause serious infections, bacterial, meningitis, and septicemia, and may also resemble Neisseria meningitidis infection. So kaya siya tinawag na subflaba is less yellow, showing yellow pigment on 48 hours in sheep's blood agar. And Neisseria elongata, unique because they are rod-shaped. And there are 3 subspecies such as elongata, glycolytica, and rhitoron-reducens. They are catalase negative kasi kadalasan ng Neisseria are catalase positive, considered as opportunistic pathogens and may actually link to endocarditis. And we also have Neisseria weaveri. So they are also unique because they are rod-shaped and found in human infections involved in dog bites. Yun. So pag nakagat pala ng aso, so possibility na magkaroon ng Neisseria weaveri. So for identification, they are catalase positive and does not produce acid from any of the carbohydrates. They can reduce nitrite to gas. In rare case, they can cause septicemia and immunocompromised patients. So kapag weak yung immune system, so there's a chance that we can get Neisseria weaveri. But buti na lang, it is sensitive to penicillin. Okay, so that ends our discussion with Neisseria. Thank you very much for listening.